être présentée en anglais. Welcome everybody to the Société Santé en français webinar, our discovery series. Today we're going to hear Sarah Bowen talk to us about the impact of language barriers in healthcare. What is the evidence? First, I'd like to tell you a little bit about Société Santé en français for those of you who may not be familiar with us. Société Santé en français and the 16 French language health networks of Canada actively work toward the healthy development of Francophone and Acadian minority communities in a quality health system that respects their cultural, social, and linguistic values. So we have 6 French language health networks across Canada. I'm a project manager here at Société Santé en français. My name is Lise Richard. The objectives for this webinar is to provide you with a better access to new knowledge. We hopefully facilitate informed decisions through evidence-based data and build networks and Société Santé en français knowledge mobilization capacity. We hope to promote interactions between knowledge producers and users as well. Just a few technical details before I introduce you to your presenter today. There will be a question period at the end. We would ask, if you look on the top left-hand side of your screen, there's a little person there. If you click on there, it'll sort of do a lift your hand action, and we will know to call your name to ask your question. Or on the bottom right-hand corner, there's a conversation box. You can write your question throughout the presentation if you like. We will be addressing those questions at the end of Sarah's presentation. Also, we'd like to remind you that unless you are speaking, that you please put your microphone on mute so as to minimize noise interference. So thank you for that. Firstly, let me now introduce you to Dr. Sarah Bowen, who is an applied research and evaluation consultant. She has a PhD in community health science from the University of Manitoba. Sarah was the Director of Research and Evaluation Unit at the Winnipeg Regional Health Authority. It was a 12-person multidisciplinary unit with the purpose of promoting and facilitating use of context-relevant evidence in policy planning and practice. Much of Sarah's research has focused on issues of concern to culturally diverse and undeserved population, with a particular focus on language barriers in health. So without further ado, Sarah, welcome, and thank you for presenting to us today. You now have the floor.
Thank you so much, Lise. Just checking that I'm coming through clearly.
Yes, you are.
Oh, wonderful. First of all, I would like to share some of my embarrassment that I'm having to do this presentation in English rather than French, as it is sponsored by SSF. It's always very reminder to me of how important language is when I am really faced with my own limitations in being able to communicate things that are really important to me and having to rely only on English. So what I'm hoping to do today is summarize findings from a critical review that I conducted on behalf of Société Santé en français, focusing specifically on the impact of language barriers on quality and safety of healthcare, and then have some time to look at my thoughts about some of the implications for moving forward. This review was a critical, not a systematic review, and I'm happy to answer questions about that later. This was really a necessary approach given how the literature is organized on this topic. and a very broad assessment of the primary research on patient safety and specific dimensions of quality. What wasn't included in the review were things like commentaries or opinion pieces. I also, because this was Canada and because we had a particular interest in official language minorities, undertook additional search strategies to try and identify literature on official language minorities in Canada. And the other thing that I spent some time doing was looking at the relationship between what are really a number of related literatures that people often get confused. And I'll speak a bit more about those, but those are the literatures on health literacy, on healthcare communication, on culture, ethnicity, and health, and the whole concept of cultural competence. But I will talk a bit more about that later. So going into this review, I had done a first review back in 2001 that was international in scope. So going into this updated review, we already knew that there was compelling international evidence on the risks of language barriers and also of using untrained interpreters, which is a common response when a language barrier is present. So the evidence looked at problems with initial access to health services, on the healthcare encounter, if people did get access, ethical standards of care, service utilization and cost, on research and service evaluation, on provider learning and satisfaction, on health outcomes, and on individual professional and organizational liability. So risks are not only to patients. What this updated review tells us, it confirms and strengthens earlier findings on the impacts of language barriers on access, satisfaction, and quality of care. But we also found some additional research. There's a lot more, for example, on chronic disease prevention and management, which is a huge issue in healthcare at the moment. Early literature tend to look at things like emergency room management rather than sort of ongoing disease. As I mentioned before, we also looked at the relationship between the literature on language barriers and that of health literacy, ethnicity, healthcare communication, and cultural competence. And it was the first detailed examination of evidence of the impact of language barriers on patient safety. And there were some somewhat unusual findings, a bit complex, that I think gives some insights for going forward. Before I go any further, I'd just like to mention that we were keeping in mind the quality dimensions as they're defined by Accreditation Canada, because that's one of the audiences that we really wanted to communicate with. So the first column you'll see labeled research category is how the language barrier literature tends to be organized. So, you know, we will say, well, there's these articles on patient safety or patient satisfaction. And on the far side, under quality dimension, is how those, that literature tends to be organized from a patient quality of care and patient safety perspective. So they don't completely align. There's some similarity, so safety is quite similar, but when we're talking about quality of care, the definitions tend to be different. So I will come back to that in a moment. Looking at the related literatures, we find that there's areas of overlap, but really important differences. So with the first area I'd like to talk about is that of ethnicity and health. So we have quite a large literature in Canada that looks at the impact of cultural beliefs, immigration status, acculturation, etc., on health. There's been some very interesting work done in the United States, mostly in the United States, trying to disentangle the effects of culture from that of language. And what that research indicates is that language is independent from culture, and it's language barriers that have the greatest impact, not what people might refer to as cultural differences. So that's a very important thing to keep in mind. And if one's chatting to minority language communities in the community, that's often what they will say as well. That the biggest problem is being able to communicate. It's not that their cultural beliefs are, different than or problematic in some way from that of the larger society. The second area of communication is around of research is around communication and health, and this is an area that has also got quite a bit of attention, and also attention to
Se joint à la conférence.
increasing providers' awareness of the importance of communicating clearly. But what we find from the literature is language barriers are a specific subcategory of communication barriers, and it's not enough to increase the communication skills of providers, that we have to treat dealing with language barriers is quite different than general good communication between patient and provider. And also we found that the patient safety research focuses on communication between providers. If you look at the whole body of literature that's under patient safety, it's often breakdown of communication, for example, between physicians when they're handing over patients. It's not focusing so much on the breakdown of communication between patient and provider. The third area that was that of health literacy. This is currently a key area of research, and what the research indicates is that language barriers may contribute to health literacy, but they also interact with health literacy and are an independent risk factor. So for example, if we have a minority language speaker who was very well educated, maybe a couple of university degrees, but can't communicate in the dominant language, their health literacy in their first language may be excellent, but they still may be at risk for things like understanding prescription information. And the fourth area is cultural competence. In Canada, we often talk about linguistic and cultural competence as though it was one large, very similar area. It's not. There are many different approaches to addressing cultural barriers. And what we see in that is there's a tension between approaches where we say, oh, let's build the capacity of healthcare providers and make them more competent and knowledgeable about people's different cultures. And that's in contrast to approaches that say, let's institute changes which allow patients to speak for themselves. We're not trying to make providers experts on the cultures of other people. So I'm just going to summarize what we know on some of the areas in healthcare about the risks of language barriers. First, about access, and there's strong and consistent evidence that access to almost every healthcare service is impacted by language barriers. Awareness of conditions and services, the whole range of health promotion and prevention activities, cancer screening, we have very good evidence on that. Whether people with chronic disease get the recommended preventive care that's needed, mental health, a whole range of other services. And what we learn from that literature is the greatest impact is on preventive and primary care services. Those are the services that require verbal assessment. And we also find that we have a very good understanding of what I call the pathways to negative impact. And by pathways, I mean that we can actually sort of follow the path of how an event happens. So this is a chart that I developed several years ago now. So you look at, what are some of the language barriers to initial contact? So lack of awareness, and those little subscripts that you may see after each of those are actual research articles that demonstrate that. Lack of awareness, means that you delay care and then you end up with higher intensity care at the end. So we actually can follow those pathways when it comes to access very easily. Also very strong evidence on patient satisfaction, that the people who have a language barrier with their providers are less satisfied. There's some limited research comparing satisfaction with bilingual providers compared to interpreters, and comparing a use of trained interpreters and ad hoc interpreters. Not as much, but there is some. And what we find that this is more than satisfaction. What we're calling patient satisfaction really is dealing with confidence in the provider and the service, that understanding leads to satisfaction. And also that if there's a language barrier, those patients tend to be excluded from things like patient satisfaction or evaluation activities. And so we don't know about specific services. We tend to have to run specific research studies to get input. There's been much more research in recent years on provider satisfaction, and we know that it affects not only satisfaction, but providers' assessment of what the risks are, their confidence in their diagnosis, and their level of concern about malpractice. In spite of that, however, the same people who express those concerns are not showing a much greater commitment to using trained interpreters or finding a language solution. So they're aware of the risks, but the follow-up and changing behavior doesn't seem to be there. The dimension of quality, I mentioned earlier that when it comes to talking about quality of care, the patient safety and the language barrier literature define it very differently. So in the patient safety literature, what quality means is the evidence that care is appropriate. It's the right treatment to the right patient at the right time. In the language barrier literature, it means that the care provided to people who face a language barrier is the same as patients who are fluent in the language. So they're really quite different definitions. But what we know quite clearly from the literature is that a language barrier provides difficulties in patient assessment, so that affects the prescribed treatment. There's sub-literatures looking at things like pain management or symptom control in terminal patients tends to be worse if there's a language barrier. Chronic disease management, hundreds of articles in this area, tending to focus on some of the bigger diseases like diabetes and asthma. In the last few years, more attention to elder and end-of-life care. This is particularly important because we also know that as people age, even if they've been fluent in a few languages during their life, they tend to lose their second or their third language and as they age, even in the absence of dementia. And of course, informed consent and confidentiality, particularly if untrained interpreters are used, are also potentially jeopardized, and that's an aspect of quality as well. Now, when it comes to safety, this is where we found some new information. Since, well, in the last 10 years, there's been more attention looking at adverse events in the face of language barriers. And a landmark study in 2007, which was undertaken by the U.S. Joint Commission, found that over 49% of adverse events were experienced by patients with limited English proficiency involved physical harm, where only 29% of adverse events for patients who spoke English well involved that harm. So they found some real differences in harm to patients in the system based on language ability. These adverse events were related both to errors of omission, which means that something should have been done and wasn't, and of commission, which means something was done that wasn't done right. And a number of indicators of safety have been used in these studies and those that have followed them. We tend to look at rates of readmission, rates of infection. In asthma, intubation is used as, because that means you're very close to dying. So if the rates of intubation are higher, that's another indication. And there's a number of issues related to length of stay. A number of studies have looked at whether people who aren't fluent in the dominant language have a longer health of stay, and it seems that in some situations and for some conditions they do. Medication safety, again, hundreds of articles, solid evidence on risks related to medication. These are mostly patient error, which is the patient does not understand the medication and how to take it. And finally, mortality, looking at the risk of death related to presence of a language barrier. There's a half a dozen or so of studies that have come out in the last few years. This is a new area. And all of these have used large administrative databases. And here we find a result that I don't think many of us were expecting. And that is that there's no evidence of increased risk of mortality and some evidence of reduced risk of dying if a language barrier is present. So if I can give an example, we have Mr. A here. He speaks some English, but not enough to understand how to take his anticoagulant medication. Okay? And there are a number of studies actually that prove, that look specifically at anticoagulant medication and find that there's a big difference in compliance and appropriate blood levels based on language proficiency. So what does the research tell us? Well, it tells us he's more likely to have a stroke and end up in hospital. We know that, so that risk is there. However, if he does have a stroke, he's no more likely to die in the hospital than fluent English speakers with similar demographic and disease characteristics. So the question arises, like, why? What are the differences? Why does everything else, access, quality of care, even the risk of having a stroke go up, but then you're not more likely to die of it? And looking in more depth at the literature, I think we can look at the following explanations, one of which is research-related factors. A big one is that we don't keep, particularly in Canada, good data on the language preferences and the language abilities of patients. So sometimes we're working with data that isn't that good. And there also sometimes are other confounding conditions. So the group that doesn't speak English, I'm thinking of one study, it turns out that that group also shows more drastic interventions. So the two groups were not exactly the same, which meant that there was a confounding condition so it may or may not have been the language that was the determination there. But I think there's a couple of other things that we need to look at more carefully. I'll go back to an issue raised earlier in this presentation, that some conditions are much more sensitive to communication, and those tend to be things that are preventive rather than immediately life-threatening. So if, for example, a person has a stroke and is taken by ambulance to hospital, their ability to communicate in the dominant language is not so critical as if they then earlier in the process when they were being assessed and being prescribed medication. They may not even be conscious. It's really going to depend on the how up-to-date and well-trained those ER staff are when they unload the patient, and the quality of care of the hospital rather than that patient's ability to communicate. What I think it also points out, though, is that language barriers do not always lead to worse outcomes. And those same studies were giving hints in this direction. Sometimes it makes providers much more cautious. So the same studies that found there was no higher risk of death found that, for example, there tended to be a longer length of stay, and there tended to be more tests undertaken. So we have a situation where we're not quite as clear how the patient is doing because they can't communicate with us as well. And so gladly, unfortunately, in many cases, the people caring for those patients will say, oh, we better be more careful. Let's run this extra test. Let's keep them for an extra day. So that is counteracting the additional risks the patients are finding. So that's very good news for the patient, not so good news for the healthcare providers. I'm not talking about the frontline providers, but the health system, because of their concern about maintaining costs and providing efficient service. We do know that when providers are more cautious, we also tend to run tests that are not completely necessary. So as we think about the findings of numbers that are crunched from large databases, here's a couple of things to keep in mind. We have to be really careful about understanding the indicators that are used. And remember, I mean, we do have a lot of faith in numbers, particularly in the healthcare system. So we have to be very cautious and make sure that we do understand what those numbers mean. So moving ahead a bit and thinking about what are the implications of this? First of all, I think we just need to reflect on what we do know. We do know that there's many risks to patients of language barriers, and I've included here a couple of quotes from the Joint Commission. Communication is a prerequisite to safe care, and poor communication from the Joint Commission research, it's been proved that poor communication is a leading root cause of sentinel events. There's also organizational and professional risks. But a huge problem is that there's very, very common misconceptions in the healthcare system. And in the work I've done, these came out very strongly. One of which is, as long as a patient speaks some English, we can get by. Actually, what the research suggests is that if people speak some English, they're often at more risk than if they don't speak any. And that is because if you really can't communicate at all, people realize there's a problem and are going to be more cautious. If people think that they can communicate, there's an illusion of understanding. Another really dangerous misconception is that, well, if I can't communicate with this patient, then, anybody can interpret. Anybody who can speak, both languages can interpret. And there is a very solid literature on the risks of using untrained interpreters, and the risks are many. We do know that there are accepted standards and ethics for interpreting, even in the Canadian context. We know how to test for language proficiency, and we do have some preliminary evidence on what are acceptable and non-acceptable responses based on evidence to addressing language barriers. So there's three, all the responses can fall into one of three categories. The first is to increase the proportion of same language encounters. So you increase the proportion of healthcare encounters where both speak the same language. You hire bilingual providers. Another approach is to provide patient language training in the dominant language. And another approach is to increase providers' language abilities. Hiring bilingual providers, what the research suggests, is not only a good but probably the best solution. However, providing patient language training is much more complex. It takes a lot of time. I mentioned earlier that people may have good second language skills and then lose them with age. Language skills that could maybe get you through a routine checkup may not be enough to understand a cancer diagnosis. And the option of providing provider language training has some risks as well. And the main one is what's called false fluency. So people think that they can communicate or that they're understanding, but they aren't. So unless we are actually testing providers' language ability, that can be risky as well. The second category is to provide interpreters, trained confidential interpreters, or what is most common in the Canadian context is ad hoc interpreters. These can be families, volunteers, bilingual staff, etc. And the third category is using translation software. Having trained confidential interpreters is a really good second best option to having a bilingual provider. On the other hand, using ad hoc untrained interpreters is not an acceptable solution. The risks are just too high. And translation software can be really, really dangerous. All of us have probably gone in and used Google Translate for something or the other, but in a healthcare situation it can be very tricky. This is what, not from this summer, from last summer, an example of something that raised a bit of fuss in New Brunswick about how difficult it is, even in a more social situation, to get a accurate translation by using Google Translate. There's a lot of things we don't know, though. We don't know the best models for addressing language barriers. Like, how do we provide efficiently quality service, particularly when there's small numbers of minority language speakers? It has to be context sensitive. And this raises a question like, is anything better than nothing? Or should there be standards that are applied to providing any kind of language access? There are also really important gaps in the research. We need to undertake comprehensive economic evaluation. where there's some good evidence that language barriers really create additional costs. The increased length of stay, the additional testing, the going to another doctor because you couldn't understand the first one, the complications that need to be treated, but we have no way of tracking that. And none of that economic evaluation has been done in Canada. In Canada, we actually have very little research that looks at official language minorities, which is a bit of a surprise. So we're having to rely on the international literature to draw conclusions about what's happening to official language minorities in Canada. And the other thing that we need to do more work on is identifying best strategies for motivating change. And this is often called the knowledge to action challenge. Well, if we know all these risks are here, why has so little action been taken on it? And it was because of this that a few years ago, a team of us in Winnipeg developed a handbook, and the teaching case in this handbook was actually providing language access. And subsequently, SSF has arranged to have it translated, and it is available online as well. So we have a number of challenges. We need to support appropriate research. We need to look at how we're defining language and have good quality data. We need to open up what I say is what I call the black box of outcome research to understand why we get certain results. And we need to have collaborative research approaches. We don't want to have people crunching numbers without understanding what the data mean and without having people who understand issues of language access on the research team. And just as, or more importantly, we do have a lot of evidence already, so we need strategies to promote evidence-informed system action. We know that the awareness of risks in the healthcare system is very low. Providing language access is sort of seen as a soft issue, or it's something we'll do if we have any resources left over. Yeah, it's a good idea, but it's not really necessary. Our work in Winnipeg indicated that out of 154 high-level risks that the organization faced, 45 of them were directly impacted by language barriers. So much, there was literature demonstrating that 45 of those 154 were impacted. So we have to move into talking about this as a risk management issue and definitely not as a cultural sensitivity issue. There's also, and this is of particular importance to official language minorities in Canada, what we found through that work is that there was much more openness to recognizing, for example, that immigrants who weren't fluent in English needed services, whereas attitudes of provision to French languages services was more mixed. And I think what our analysis of the more recent research indicates is that we're relying on individual healthcare providers to provide safety to patients who have a language barrier rather than having the system take responsibility for that. So that is, brings us to the end of my initial presentation. I'm certainly looking forward to having more discussion and would welcome your questions at this time.
Thank you very much, Dr. Bowen, for your presentation, for sharing your findings from the literary review. We've certainly found here at the SSF, that Société Santé français, that it's been helpful to us in talking to partners about the importance of Francophone services in healthcare. It's giving us some valuable arguments and also gives us some things to consider when we're suggesting models or tools for to be able to provide those services. Um, we will now take questions, and again, you can either lift your hand up on the left-hand side of the screen or write your question on the bottom right corner under the conversation box. Sarah, if you do have video capacity, perhaps for the question period, if you could turn on your video, it's next to the microphone on top. It's to the right of the microphone to give that capacity, if you do have that capacity.
I do, and I can see myself on it.
Oh, if you, I think on top of the video where you can see yourself, there's Démarrer ma webcam, or it says you just hit that little button and it will provide others the ability to see you as well.
Did that work?
Not yet, but that's okay. Nope. Any questions? You can also ask them verbally if it's easier. There are questions coming. We just wait for the questions to appear on in the conversation box. So we have a question from Antoine, who's asking Dr. Bowen, in your research, have you encountered a sentinel event in Canada linked to linguistic barriers?
That's a really good question. I'm trying to recall some to mind. There have been a couple of cases that actually went to court. For example, an abortion that wasn't wanted, and because of delayed care, a man having a leg amputated. What we did in the Winnipeg context, this was several years ago, we found that decision makers, they were, you know, it's funny because they say, well, show us the research, we want the numbers. So you show them the research and the numbers and they say, yeah, but how do we know that's going on in Winnipeg? So they also wanted the stories. So we actually went out and collected a whole set of stories from frontline providers that were, and some of them were documented in a report that I wrote that is available if you wanted to contact me later. So yes, we have found some. Not all were sentinel events, some were adverse events, some were just really sad stories. But yes, there are Canadian examples.
Thank you, Sarah. There's another comment and question from Geneviève Laferrière, who says, hello, Sarah. Thank you for your excellent presentation. I have a question regarding false fluency. Does the language competency level impact this at all? For instance, if a provider is at an intermediate level versus beginner level?
Definitely, but I think another aspect of this is really provider insight as to their language level and caution. Some of the easiest mistakes to make are those when words are, you think they're similar in both languages, but they have different meanings. And the ones that come to mind for me are Spanish and English, so I'm not able to give you some good French ones. I'll remember as soon as I get off the phone. But certainly, what we're looking for is people to be as close to, you know, completely fluent in both languages possible. Because limping through on a language, I could actually go to a restaurant and do okay in French, but you sure wouldn't want me to be providing care to anybody.
Thank you. The following question is from Suzanne Dupuis-Blanchard, who's from New Brunswick. She says, thank you for an excellent presentation. Do you have any ideas as to how to get the private sector to offer bilingual services? For example, here in New Brunswick, home care services are mostly provided by private industry in partnership with government, but they are not obligated to offer bilingual services.
I'm not sure if I have the answer to that, but I'm certainly think we need to pay more attention to the question of what's in it for them. And private business is even more sensitive, I think, to where are the efficiencies in this for us if we provide language access. And in something like home care, one would think that it would be actually easier to ensure a language match than, for example, some of the more specialized sub areas, like, neurologists, for example, compared to a home care worker, would be much easier to find and recruit a bilingual person. So I think trying to sell it as this is good business. Looking more broadly at the business literature, it's interesting that it's banks and hotels that have been way ahead of promoting language access over healthcare, and it's because it's good business. Okay, so I think that's the argument we have to make as the business case.
An interesting comparison.
It doesn't match it. So I guess I'm just reading the comment that provider and client matching does not always consider language, unfortunately. So I think the only way around that is really to look at, there has to be some awareness raising with the decision makers in those organizations. And some of the awareness raising is like, why should we care? Right? Because it does provide another level of complexity to matching, but if they can really see what the advantages are, both to the quality of care that is being provided, and conceivably also to the efficiency of services being provided, then they may take it more seriously. The awareness of the risks is very low, and I'm sure that in dealing with management of those services, it would be very similar to dealing with senior management of the health system. First, people have to be aware there's a problem. And in the handbook that we developed, we really came to the conclusion that the first step is to have people acknowledge that there is an issue. And there's no point in presenting solutions unless people have already come to the point of saying, oh yeah, there is a problem, we should do something. And then to move in and say, well, these are some of the things that we might want to do. I hope that helps.
Thank you. And Suzanne's responding by saying, yes, awareness is key. Thank you so much. Thank you again, Dr. Bowen. Does anybody else have questions that they would like to ask either online or in the conversation box? Caroline is writing at the moment, saying thank you, Sarah.
Oh, and here I was hoping for a question from Caroline.
Okay, if there are no other questions, I'd like to take this opportunity to firstly thank you again, Dr. Bowen, for your presentation and for the conversation that it provided. I also would like to thank everyone who attended today's presentation and for your questions. We would like to ask you to please answer the evaluation questionnaire that will pop up at the end of this presentation, and it's also you'll see the link in the conversation box on the bottom. We'd also like to make you aware that the Sarah Bowen's literary review is available if you would like to have it. And you can email Eve Laframboise if you would like a copy. Her email address is also in the conversation box. And there's also a summary of Dr. Bowen's review as well. So you're welcome to request that. So thank you again, and I hope you have a wonderful rest of Wednesday. Take good care.
Thank you, Lise.